This presentation will cover ruptured intracranial aneurysms and arteriovenous malformations as part of our neuro chapter. A cerebral aneurysm, also called an intracranial aneurysm or brain aneurysm, is a bulging, weakened area in the wall of an artery in the brain, resulting in an abnormal widening or ballooning. Because there is a weakened spot in the artery wall, there is a risk for rupture or bursting of the aneurysm. A cerebral aneurysm generally occurs in an artery located in the front part of the brain, which supplies oxygen-rich blood to the brain tissue. A normal artery wall is made up of 3 layers. The aneurysm wall is thin and weak because of an abnormal loss or absence of the muscular layer of the artery wall, leaving only 2 layers. Causes of intracranial aneurysm may include a developmental defect in the vessel wall and degeneration of fragility of the vessel wall due to conditions such as hypertension, atherosclerosis, and abnormal blood flow. A developmental defect in the vessel wall is caused by a connective tissue disease called Marfan's. The most common type of cerebral aneurysm is called a saccular or berry aneurysm, occurring in 90% of cerebral aneurysms. This type of aneurysm looks like a berry with a narrow stem. More than one aneurysm may be present at the same time. 2 other types of cerebral aneurysms are fusiform and dissecting aneurysms. A fusiform aneurysm bulges out on all sides circumferentially. Fusiform aneurysms are generally associated with atherosclerosis. A dissecting aneurysm may result from a tear in the inner layer of the artery wall, causing blood to leak into the layers. This may cause a ballooning out on one side of the artery wall, or it may block off or obstruct blood flow through the artery. Dissecting aneurysms may occur with traumatic injury. The shape and location of the aneurysm may affect what treatment is performed. We also see some mycotic aneurysms, and these result from emboli from infections. Ruptured intracranial aneurysms result from atherosclerosis, as we said before, but also hypertension, even from congenital defects and trauma to the head, and aging. In fact, ruptured intracranial aneurysms are the most common cause of hemorrhagic strokes, and it is most common in adults between the ages of 30 and 60. The rupture will occur at the site of weakness in the vessel wall. On this slide, we see the arterial circulation of the brain. At rupture, the client experiences a sudden explosive headache, loss of consciousness, nausea and vomiting, stiff neck, photophobia, and cranial nerve deficits, stroke syndrome manifestations, and pituitary manifestations. Major complications of a ruptured intracranial aneurysm are rebleeding, vasospasm, and hydrocephalus. Ruptured intracranial aneurysms can lead to a subsequent subarachnoid hemorrhage. Subarachnoid hemorrhages are graded according to their signs and symptoms or manifestations. The Hunt-Hess classification of subarachnoid manifestations is presented on this slide. There is no need to memorize this, but it is an indication of a worsening of the subarachnoid hemorrhage, a worsening condition of the patient. Note that on grade 5, we see that decerebrate posturing is caused. And this is an injury indicating an injury at the level of the brain stem. And basically, it means that your brain isn't working anymore. A cerebral angiogram is the gold standard for evaluating cerebral aneurysms. Bilateral, carotid, and vertebral cerebral angiography can be used to determine the site and size of the aneurysm. CAT scan and lumbar puncture may also be performed. The CAT scan demonstrates blood in the subarachnoid space within 24 to 48 hours after rupture. Lumbar puncture is used to confirm subarachnoid hemorrhage, but does have the associated risks of rebleeding and brain herniation. Medications that may be prescribed for ruptured intracranial aneurysms include Amicar, which is a fibrinolysis inhibitor. It's used to treat excessive bleeding in acute life-threatening situations. It's used in the first 2 weeks after the event to reduce the risk of rebleeding. Calcium channel blockers, such as nimodipine, are used to improve neurological deficits due to vasospasm. This is administered for 3 weeks after hemorrhage and reduces ischemic deficits from arterial spasm. Calcium channel blockers are used to improve neurological deficits due to vasospasm. Other medications that may be prescribed include anticonvulsants, analgesics, and stool softeners. Anticonvulsants are used to prevent seizures if increased intracranial pressure develops. Stool softeners are used to prevent constipation and straining with bowel movement. Analgesics are administered for headache. Surgical clipping is a procedure that involves the surgical removal of part of the skull, which is an open craniotomy. The physician exposes the aneurysm and places a metal clip across the neck of the aneurysm to prevent blood flow into the aneurysm sac. Once the clipping is completed, the skull is sutured back together. This usually entails a week-long hospitalization and approximately a month to recover from this procedure. Endovascular coiling or coil embolization is another primary surgical treatment for a cerebral aneurysm. Endovascular coiling is a minimally invasive technique, which means an incision in the skull is not required to treat the cerebral aneurysm. Rather, a catheter is advanced from a blood vessel in the groin up into the blood vessels in the brain. Fluoroscopy will be used to assist in advancing the catheter to the head and into the aneurysm. Once the catheter is in place, very tiny platinum coils are advanced through the catheter into the aneurysm. These tiny, soft platinum coils, which are visible on X-ray, conform to the shape of the aneurysm. The coiled aneurysm becomes clotted off, embolization, preventing rupture. This procedure is performed either under general or local anesthesia. The images in this slide reveal an intracranial aneurysm on the left and the same aneurysm after completing the surgical endovascular coiling treatment. We can see the platinum coils conforming to the shape of the aneurysm, thus clotting off and preventing rupture of the aneurysm. Some people are candidates for endovascular stent repair. A stent is a tiny tube used to prop open a vessel. Because it does not require open surgery, this procedure can allow the patient to recover faster. However, not all patients with aneurysms are candidates for stenting. While this example may be outdated, there was a famous actress named Sharon Stone who had an intracranial aneurysm. Remember, approximately 5 million North Americans have intracranial aneurysms, although most are asymptomatic. Rupture of an intracranial aneurysm occurs in about 30,000 people every year, and sadly, 2/3 of the survivors will have serious disabilities. But Sharon Stone is an example of how diagnostics were used in the identification of a vascular aneurysm. She had 2 angiograms, the gold standard, performed a week apart. And then she had also an MRI, which was used to define the bleeding. Okay, so her surgical treatment was endovascular coil embolization, which we already described as a soft titanium wire being threaded into the artery and lodging there near the leakage site to stop the bleeding. The nursing diagnosis, ineffective tissue perfusion, cerebral, is an appropriate nursing diagnosis for individuals who have had a ruptured intracranial aneurysm. Let's remember some nursing interventions. Maintain the head of the bed at least 30 degrees. Provide a quiet environment. Monitor vital signs and neurological status. Remember to implement measures to avoid increasing intracranial pressures. The next topic of our presentation is arteriovenous malformations, frequently abbreviated as AVM. An arteriovenous malformation is a congenital intracranial lesion. It's formed by a tangled collection of dilated arteries and veins that allows blood to flow directly from the arterial system into the venous system. This condition occurs when arteries in the brain connect directly to nearby veins without having the normal vessels or capillaries between them. Clients with this condition develop manifestations before the age of 40, and it does account for 2% of strokes. Manifestations are the result of spontaneous bleeding from the lesion into the subarachnoid space or brain tissue. AVMs vary in their size and location within the brain, and there are no symptoms until the AVM ruptures. Altered cerebral perfusion certainly can result from spontaneous bleeding from the lesion, and also can result from the vascular steal phenomenon. Because of the decreased resistance, i.e. the lack of capillaries, blood wants to flow through this area of the lesion, then robbing the surrounding brain tissue from oxygenated blood. Manifestations or symptoms vary depending on the size of the malformation. Small malformations may lead to neurologic deficits, while large malformations may lead to seizures. The symptoms of an AVM rupture are similar to a stroke and occur because of a lack of blood flow to the brain. Symptoms may also occur when large AVMs press on the brain tissue, which can cause nerve damage and blood flow problems. There are no symptoms until the AVM ruptures generally. When it ruptures, it results in sudden bleeding or a hemorrhagic stroke. In more than half of the patients with AVM, hemorrhage is the first symptom. Again, depending on the location and severity of the bleed, the hemorrhage can be very disabling or even deadly. So manifestations can be seizure activity, especially with large malformations. Also, recurrent headaches could be a symptom. Headaches that are not responsive to treatment could indicate the presence of an AVM. Diagnostic tests to be used in these cases would be CAT scan and MRI, but once again, and as we see in this picture, cerebral angiography is the gold standard. Okay, so with this one, we can see the AVM, this tangled mass of arteries and veins in the cerebral angiography or angiogram. Nursing care of the client who has not experienced hemorrhage focuses on preventive education. Points to be made. Patients should avoid activities that raise blood pressure. Patients should avoid activities that could cause injury, such as school sports. Patients should take medications to control their blood pressure and to prevent seizures. If hemorrhage has occurred, nursing care is the same as for any patient who has had a hemorrhagic stroke.